Good afternoon, everyone. Just want to give it a couple of minutes before I start.
Okay, I think we'll get started. Hi, everyone. Thank you for joining us today. My name is Kerry Grady Vincent, and I'm the Senior Manager of Scientific and Clinical Programs at Osteoporosis Canada. I will be your moderator for today's webinar entitled Information for Healthcare Providers on the Health Canada recently approved biosimilar for Denosumab. Before we begin, Osteoporosis Canada acknowledges the land that our offices located in Toronto are on as the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. At Osteoporosis Canada, we educate Canadians about bone and muscle health, including healthcare professionals and their clients. We are the only national organization serving people who have or are at risk for osteoporosis. We are excited about today's presentation for healthcare professionals, which will provide information about Health Canada's recently approved biosimilar for Denosumab. OC provides medically accurate information to patients, healthcare providers, and the public. Our services include programs and support groups, educational webinars, podcasts, digital tools, and community resources, all available on our website at osteoporosis.ca. Today's presentation is not intended as individualized healthcare advice. If you do have questions during the webinar, remember to click the question and answer button on your screen to submit your questions, and we will try to get to as many as we can, time permitting. Before we begin, make sure you have your speakers turned up fully so that you can hear the presentation clearly. It is now my pleasure to introduce our speaker, Dr. Angela Cheung. Angela is a professor of medicine, the Kai and Betty Ho Chair in Integrative Medicine at the University of Toronto, and Senior Physician Scientist at UHN Network. She is the founding director of the Osteoporosis Program at the University Health Network and the founding director of the Center of Excellence in Skeletal Health Assessment at the University of Toronto. She is a fellow of the Royal College of Physicians of Canada and has been in clinical practice for more than 30 years. Angela has won many research, teaching, and mentorship awards over the years, including the most recent at the ASBMR this year, the Gideon Rodin's Mentorship Award. She currently holds a Tier 1 Canada Research Chair in Postmenopausal and Musculoskeletal Health. Dr. Cheung is a past chair of Osteoporosis Canada's Scientific Advisory Council. She is a current member of the International Osteoporosis Foundation Council of Scientific Advisors and the president-elect for International Society for Clinical Densitometry. She has published over 250 peer-reviewed manuscripts and has an H-index of 75. Her research interests are in postmenopausal osteoporosis, atypical femoral fractures, and rare bone diseases. So without further ado, please join me in welcoming Angela. Angela, take it away.
Thank you. Thank you, Kerry. So let me see if I can share my screen. I too am grateful to be working and living in Toronto, sort of on lands of Treaty 13 as well. So biosimilars in osteoporosis. So these are my disclosures. I've served as a consultant for Amgen and Ipsen, and I hold grants that go to my institution from Insight, Ipsen, and Sanofi. And you heard a little bit about the non-industry disclosures. So what I'm hoping to do today is over the next 35 minutes to go over sort of what are biologics and biosimilars, and how does the first biologic for Denosumab compare with our current product on the market. And what do we need to know regarding transition to a biosimilar? So let's go over what biologics and biosimilars are. So biologics are made from living organisms or their cells. And there are many examples, for example, vaccines, blood components, gene therapy, cell or tissue therapy, and also recombinant proteins. So denosumab, anything that ends with a monoclonal antibody, is one of these recombinant proteins. And they are complex products. Biosimilar is a biologic that's similar to a reference product. So in this case, we're talking about denosumab. And I like to use the pizza analogy. So there's no generics in the biologic world because everything is a bit different. And so it's not just a chemical structure that you can swallow. And biologics tend to be injections and infusions because they do get degraded by stomach acid and digestion. So the biosimilar analogy is that you order a vegetarian pizza and from different places, and you can see that there are two different pizzas. They look quite different, but I would say they're both vegetarian. And if you don't like olives, you may not like the top pizza. Whereas if you really like olives, the top pizza may be your preference. So there's another term called interchangeable biosimilars. And so that means that they produce clinical results similar to the reference product. And that's what we're talking about today as well. So the analogy to pizza is that you want to order a vegetarian pizza without sort of olives. You have very specific requests for the pizza. You like mushrooms, you like tomatoes, you like bell peppers, and you want basil on it. And so you may be ordering two different ones from two different companies, for example, Pizza Hut or Pizza Pizza. And those are considered, you know, if it's the same ingredients, it's considered a interchangeable pizza, although you may prefer one to another. So I want to give you a little bit of history about sort of biological medicines over the past decade in Canada. So biologic sales in Canada nearly tripled over the last 10 years, rising from 3.8 billion to 11.1 billion in 2021. And this represents a 10-year compound annual growth rate of about 12.5%. And the sales of biologic medicines accounted for more than a third of pharmaceutical spending in Canada in 2021. And if you look at per capita costs, it's about 290. And Canada ranked fourth among the OECD countries for biologic spending. You can see US is the first, and Belgium, Australia, and Canada rank fourth. And it is exceeding so it's 34.8%. It's exceeding the OECD median of 27.9%. So the median per capita is $174 per person, whereas actually Canada spent $290 amongst most industrialized countries. And the availability of biosimilars in Canada has increased, but it didn't really affect the overall cost of pharmaceuticals. So if you look at this, it's for different biologic medicine. You can see many of them actually end with an MAB kind of ending. And EU or EMA in Europe has European Medicine Agency is actually 15.1% in terms of biosimilar sales of overall biologics. Whereas in the US is 4.4% and Canada is actually somewhere in the middle. And if you look at also sort of the number of biologic medicine sort of that has been approved, you can see also it's in the middle as well. Currently, there are 55 biosimilars. So this graph was taken from a presentation in 2023, but it has been really exploding. So currently, there are 55 biosimilars on the market in Canada. And so many Canadian public drug plans and have tried to take initiatives to increase the biosimilar uptake because it's cheaper, it's more accessible and more affordable. And so BC took a lead in May of 2019, and it's the first Canadian province to initiate a switch to biosimilar medicines for patients covered under their provincial plan. And Ontario announced their biosimilar switching policy coming into effect as of March 2023 as well. So, and many other provinces are have various plans that have been effective over the last few years. So this is taken from the Osteoporosis Canada website, and Health Canada provided authorization to market the first Denosumab biosimilar called Jubbonti, which is made by Sandoz. And it was approved in February 2024 and is currently on the market. And so that's why we're going through today to look at what we know about this product. So this is Jubbonti versus Prolia. So when there's a biosimilar trying to be marketed, usually these are the steps to get marketed. Is you need analytical characterization, so using mass spec to characterize the primary structure and using various methods to look at the higher order structure and also variant analysis, because these are made by cells rather than they are sort of like grown in labs and not sort of manufactured per se. And also you need functional characterization, looking at mode of action, the target binding, and the effector function. And then you also need clinical studies. So for this biosimilar, there is a phase 1 study looking at pharmacokinetics and pharmacodynamics. And then there's a phase 3 study, the Rosalia study, also looking at similar endpoints as well. The phase 1 study was 499 patients. The Rosalia study is 520 something patients. So I'm going to go through some of these data with you coming up. So when we actually look at comparison of potency, this is done by self-based reporter gene assay of the Sandoz compound. So it's the number is GP 2411. On the left, you can see that it's the US reference Denosumab, so Prolia from the US. On the right is the European reference Denosumab, so that's Prolia from Europe. And usually we look at plus or minus 2.5 standard deviation. And so the active ingredient, which is in powder form, is in the middle here. And the final product, which is in liquid, is in here. And so certainly it falls within the ranges that is seen with the reference denosumab compound. Then we want to look at pharmacokinetics and pharmacodynamics. And so I just want to explain what these two words mean. So pharmacokinetics mean that we're asking the question of what does the body do to the drug? How does it absorb it? How is it distributed? How is it metabolized and excreted? Pharmacodynamics mean what does the drug do to the body? Meaning the effect. So we know denosumab is an anti-resorptive drug, so we have desirable effects like anti-resorptive effects, and undesirable effects mean adverse effects. And so when you combine these two, you're really looking at drug concentrations and the effect of the drug. So this is the phase 1 study looking at how it compares. And here it says Xgeva because the branded denosumab for cancer, which is much higher dose, is the reference. And you can see that there are different reference. And they are all within the pre-specified equivalence margin of 0.8, which is the dotted line here, to 1.25, which is the dotted line here. These kinds of intervals are quite well accepted in the clinical world for equivalence. So then these are the PD studies, so pharmacodynamic studies, and you can also see the different ones, and they look very similar around 1 as well in terms of the effect of it. So overall, the PK and PKD studies look pretty good in the phase 1 study. I'm going to spend a little more time on the phase 3 study. So this is the phase 3 study, 527 postmenopausal women with osteoporosis, randomized 1-to-1 to the biosimilar Jubbonti or the European-made Prolia. So 263 here, 264 there. And they got 3 doses. The first one, day 1, the second one in 6 months' time, and then at the 1-year time point, there's a switch from the group that was on Prolia was switched to Jubbonti and or randomized to stay on Prolia. And so this is what we're looking at as well. So we're looking at the time treatment period 1 and also treatment period 2, where there are really 3 groups. One group stays all the way on the biosimilar. A second group was a switch group. And the third group is really the staying on the branded Prolia. So this is just another way to look at this. 527 people split into the biosimilar versus the reference one, and the biosimilar stays, and then the reference one, part of it stays. So this is the second group here, stays. 123 patients completed only the branded version. And then half the group was split into randomized to the biosimilar. So this group is started with the branded compound and switched to the biosimilar. So when you look at drug concentration after first dose, there's really no difference. The 2 curves overlap. So the biosimilar is the open circle, and the reference is the dotted blue line. And you can see that both of these overlap quite well. Then we want to look at the bone turnover markers over time. And so again, the biosimilar is the The biosimilar is the yellow one. So you can see they overlap exactly over time as well. Both for bone turnover marker CTX, which is a resorption marker, and P1NP, which is a bone formation marker. And I think what's of interest to clinicians is really change in lumbar spine bone density. And so you can see the three groups are very similar as well. Those in the dot in the blue, which is just the biosimilar. In the gray is just the branded Denosumab. And then in the yellow is the switch group. You can see that this was the primary outcome. And they are considered equivalent in terms of change in bone density in the spine. Change in bone density in the femoral neck is no different. Like you can see these curves overlap significantly. And the same for change in total hip as well. These curves are overlap significantly. And so when we look at adverse and safety events, there were 59.7% treatment emergent adverse events in the biosimilar and 68.6% in the branded Denosumab. And if you look what are the common ones that is of interest to us, hypocalcemia is one of them. They're very similar, 10.7% for biosimilar, 11.2% for the branded Denosumab. And of course, what's of interest to me is what about fractures? So this study was not really, the sample size was not for fractures per se, but you can see they're very similar as well. New vert fracture was 9.9% in the biosimilar and 13.6% in the branded version. And the combined one, meaning switch from branded to biosimilar, was 13.7%. And similarly, the non-hip non-vert fracture was 0.4 versus 0%, very tiny numbers here, with the combined being 0.8%. The other piece for all these monoclonal antibodies, we're interested in anti-drug antibodies. And they are very similar as well between the biosimilar and the branded one. Both in period 1, there's a typo here. It's actually, the first one should be period 1 for Prolia. And then the second one would be a period 2, and they're very similar. And these numbers may be a lot higher than the usual, the studies on Prolia, partly because it's a different measurement and it's a more sensitive assay. And I would say most of these were really not really counted as having significant anti-drug antibodies, because usually the lower cutoff is 10. And most of these are like 9 and below. I think there were maybe 1 or 2 that was slightly above that. So on a clinical basis, there were really no differences between the two products. So I want to share with you some information about the transition as well. So you can see the first province was BC. And they adjudicated on both Jubbonti and Wyost. Wyost is the sort of Xgeva biosimilar, so the dose is different. And you can see that they are saying that it starts August 29th, and by March 3rd, 2025, they would not cover they would not cover for the branded product under the provincial plan. So the switch was 6 months. And I would say most provinces, that's how the transition period is about 6 months. So this is a list of the current sort of provincial funding and transition. So you can see in BC, it's listed and funded, and you have a date for the transition. In Manitoba, it's similar with an end date that's earlier, February 25th, 2025. Nova Scotia and Newfoundland will end a little bit later. And the transition period is September and October. And so you can sort of see that different provinces and different provincial plans have slightly different dates. For Ontario, the funding of Denosumab was approved by the Ontario Drug Program in September. And in Ontario, there are 2 transition periods, one in May and one in November. So this biosimilar will start, the clock will start in November, which means by end of April of next year, the transition will need to take place. So there are different sort of codes for, so this is the LU criteria for Denosumab, 687 and 688 for the biosimilar. And there is a fee for patient for supporting people transitioning. So because physicians need to do a prescription, there is like for a physician office to call. You can use a K900A code for a fee of $61 for the it's a physician fee. And the pharmacies are also support may submit a claim as well for $15. And so that's Ontario. In BC, it's $50 and $15. So it's a little bit different. For private insurance, it's really determined by each insurance company. Currently, I don't know of any transition plans. But I do expect it may be required in the future, so similar to the US. And so people who have been on Prolia can stay on Prolia with private insurance. But as more biosimilars are approved for Denosumab, and I expect there are at least 2 more this coming year. Insurance companies will likely follow the provincial plans. And so I think sort of transition may be required in the future. So the cost per dose, if someone has to pay out of pocket, is $194 for the biosimilar and $440 for the branded one. Although the branded one has plans where, depending on your income, for people using private insurance, there may be a copay that is sort of canceled as well. So those are some of the possibilities. So actually, you may not be paying the $440. So to summarize, Jubbonti is the first Denosumab biosimilar in Canada. There are phase 1 and 3 studies showing that it is interchangeable with Prolia, with similar BMD changes and similar adverse events. There will be more biosimilars for Denosumab in the coming year. So the advantage of using a biosimilar is that it's cheaper, it's more affordable, it's more accessible, but they are not the same product. And, there may be patients who may not tolerate. And if that's the case, may need to go through the exceptional access program to sort of argue for your physician for the physician to advocate for why they need to stay on the branded product. One thing I want to note is that whatever the switch or no switch, please do not allow a gap in the treatment with denosumab. Because we know that if you don't treat on time, people can lose bone density and lose bone and can have vertebral fractures. And so this is an important note as well. So I'm going to stop here and happy to answer any questions.
All right. Thanks, Angela. That was great. Lots of information for everyone to think about. We do have a few questions, and we'll start with this one. Do prescription drugs, such as something for acid reflux, significantly affect the efficacy of Jubbonti?
The answer is no. Both the branded and the biosimilar are injectables. So PPIs, so proton pump inhibitors, are taken orally and only affects sort of oral medications.
Okay. Next question. I think you've answered this, but it's probably good to repeat. How long is the transition period for patients depending on, I guess, where they reside in Canada?
So you can see from the graph, let me just see if I can go back. Okay, let me just see if I can. Let me just see if I can go back to this chart here. So every province is different. And so it is really this one. Sorry, let me just see if I can share it again. Okay. Do you see this graph? Let me just see. Yeah. This chart. So every province is similar. It's different. And so, for example, in Alberta, it's currently under review. In Saskatchewan is under review as well. So there's no transition. In Ontario, it's listed, but there are no dates because the expectation is that the transition will start in November and will finish in April. So, but it's not been announced yet. But based on sort of the rules, and so most provinces are using the 6-month rule, but some provinces like Ontario they only have 2 transition periods annually, either beginning in May or November for 6 months. So it may vary by province.
Okay. Thank you. Next question is, from both a clinical and patient perspective, what action is required if the patient requests to continue on Prolia, as they would be responsible for the additional costs?
Yeah, so I think there are 2 ways. One is the patient is paying for it. And there may be a finance program that may help with some of that if you are self-pay, but you won't be covered by the sort of provincial drug plan.
Okay. Thanks, Angela. Next question. If my patient has pre-existing conditions or is currently in treatment, are there concerns regarding side effects on using the new medication?
So if someone is already in treatment, that's what's called the transition, right? So based on the study that you saw, there are like both actually the phase 1 and phase 3 studies, so a total of about a little bit more than 1,000 patients. There are no big differences in side effects. But that's from a group perspective. So if your patient experience side effects, then you will need to sort of do other things to sort of justify staying on it. And it will be adjudicated. So in Ontario, it would be through the exceptional access program.
Great. Another question that just came in. For the effects on BMD and bone markers, you gave confidence intervals which overlapped a lot. Do the confidence intervals for adverse effects also overlap similarly?
Yeah, so actually it's the confidence interval is quite wide, but actually the line overlaps like quite significantly. So like let me just see if I can share again. Hang on 1 second. Just have to do this one more time. So here. So if you look at the drug concentration after the first dose, the two curves overlap exactly. And yes, there are confidence intervals, and yes, the confidence intervals of these two also overlap as well. And same with bone turnover markers. If you look, the lines totally overlap. And yes, the confidence intervals overlap as well. And same with bone density stuff as well. The lines almost overlap and the confidence intervals overlap. And so for adverse events, it's much fewer. So it's not like 200 and something people. And so the percentage overlaps. That's correct. So you saw me sort of doing this chart for hypocalcemia, 10.7% versus 11.2%. And it's really very similar in terms of these two things. They are considered similar, basically.
Okay, great. Okay, one last question from our audience is, how long does it take to see a significant result in the bone density for the biosimilar? Can a patient stop it at any time for any side effect reason?
So this is so like how soon can you see an effect? Well, 6 months. If so lumbar spine BMD in a good lab, you may be able to see at 6 months and definitely at 12 months. But everyone is different, right? So you can be here on the curve, but on average, people gain bone density the same rate, whether it's on a biosimilar or the branded product.
Okay. Well, thank you, Angela. That was great. Thanks for all the information on biosimilars. I greatly appreciate that. I just want to say, for more information on osteoporosis, please visit our website at osteoporosis.ca. Our website includes many tools, including our updated nutrient calculator, podcasts, quizzes, and a repository of past webinars, as well as listings for future events for both yourself and your patients. You can see what's on the screen right now, what's coming up. And thanks to all of you for joining us today. Please subscribe to our newsletters for up-to-date information. And until we meet again, wishing you a great day. Thanks again, Angela, and have a good day, everyone. Thank you.
Great. Thank you. Bye-bye.